There's 41 people on so far.
Okay. It's open. I'm not sure about it. Oh, okay, we're on. Okay, everybody. Good afternoon. It's Jo Root here from CHF, and just in honour of our guests, hello, my name is Jo. It's something we often actually neglect to do when we meet people, particularly in a professional capacity, but also to make people feel comfortable. It's my great pleasure today to welcome you to this webinar and to welcome our guest presenter, Chris Pointon from the hellomynameis campaign. Chris, I think, is going to introduce himself and talk you through some of the aspects of the campaign, and then it's really over to all of you to ask some questions. Those who've been on our webinars before know to type in your question at the bottom of the screen in the chat thing. We'll then translate the questions into a slide to have a look at, and we'll answer your questions. We're hoping this is going to be as interactive as this format will allow us to be. We've got some questions that people have already sent in, so thank you to those, and we've thought up some ourselves because we're good policy people and can always dream up a question. So without more ado, do you want to talk first and then do the video, or do you want to do the video first?
I think we'll do the video.
Okay, well, this is where I just managed not to do it. He did tell me where it was.
Hello, my name is Chris.
Hello, my name is Chris.
I'm from the UK, work for AHHA, been there for 17 years, and I currently am a supply chain manager in the fresh food supply business. So Kate and I met on New Year's Eve at the end of the year 2001. It's one of those moments where it was certainly love at first sight. Kate finished her studies in 2005. She got a job as a junior doctor in one of our local hospitals, and literally a month after Kate finished at university, we were married. We took a well-deserved holiday to California, where we've got family and friends who live there, and it was apparent, sort of second week into our holiday, that Kate wasn't feeling very well. I made the decision that we had to go into ER. Is it a cancer you're going to survive from? No, it's not. She was given sort of 6 to 12 months to live, which, to be told that when we were thinking about starting a family and knowing what Kate brought to the world, yes, it was heartbreaking for everyone involved, and especially to Kate and to myself. It's a type of sarcoma. It stands for a desmoplastic small round cell tumour. She'd gone through a period of chemotherapy, and she was in hospital for an admission to, give her antibiotics to look after her. And there was one particular day when she wasn't feeling great, and she was getting really agitated by the lack of introductions from healthcare workers. So I said to Kate, why don't you use your already big social media presence? And at that point, Kate had around 24,000 followers on Twitter. Why don't we come up with something like, I don't know, #hellomynameis, and see how it goes? And at that point, Kate tweeted something out, and it was born. Before we knew it, we were getting photographs from hospitals across the UK and starting to spread across the world. I know it's been endorsed by very senior people across Walmart, and it makes me feel proud of the organisation that I work in, but I know that Kate was comfortable knowing that I'd be looked after after she passed away. My vision and my thoughts for 23rd of July every year going forward is that I want that to be recognised as an International hellomynameis Day. One, to celebrate the campaign, but secondly to celebrate the life of an amazing lady that Kate was. Through all the bad stuff that Kate was going through and through all the adversity that she was going through, she made a difference to other people. I've been through a tough 12 months. You know, my personal ambition is to make sure that it continues, and it will continue across the world. It's 4 words. It takes very little time. It starts a human relationship between 2 people. The patient should be at the heart of every decision that's made. If I could walk into any hospital anywhere in the world and for somebody in there to know about the campaign, then I'd be happy.
Okay, so that's given people an idea of the campaign. Do you want to add anything to what's on the video, Chris, to start off with?
Yeah, so good afternoon, everyone. Hello, my name is Chris Pointon. Can't really start any talk or any webinar without using those that have now become quite iconic across healthcare and across all walks of life. And the reason why we started with showing that video is it gives a very brief outline as to why the campaign started, the timelines involved with the campaign and with my late wife, and also to show that it's not just in healthcare. This is something that is pertinent across every walk of life. And it's a human interaction. You know, it's 2 people introducing themselves to each other, which then forms a better relationship and a better communication. And I noticed from some of the comments that are coming through that some might not have been able to see the video, but you know, it's freely available on YouTube. So by all means, you know, watch that at a later point. And there's various other videos on there as well around the campaign and around Kate and around myself. But yeah, it's a pleasure to be here, and it's a pleasure to be able to answer any questions you may have and talk about the campaign and talk about something that's really making a difference to other people. And you know, the big selling points of the campaign are it takes very little time to do, it costs very little money, and it does make that difference. So I appreciate all your support and any questions that you may have. But yeah, it's a pleasure to be here.
And I'd just add that we will put a link to the video on with the webinar link so that you can see it if you've missed it, and we apologise for that. I guess going to some of the issues, Chris, you've been in Australia a few days now, you told me, for a reason, apart from it being warmer. Do you notice any difference about how people react to the campaign here to say in England? Is there anything that stands out particularly?
I think, you know, from visiting different countries and from being back in Australia, I was over here in September, you know, the passion and the enthusiasm that's shown by people is huge, and it's great. And, you know, a lot of hospitals have already adopted the campaign even before I visited last September across Australia, and it makes me feel really proud of how the campaign that was started in Yorkshire in the UK has grown into something that is a global success and a global campaign. I suppose, as in any country, you're always going to get people that would put barriers up against the campaign, but then also you get those people that are really ambassador campaign and really do help promote the campaign because they get the idea, they get the concept, which is the biggest part of the campaign. It's just so simple. The question is, why would you not want to do it?
So why do you think people weren't introducing themselves? You know, the question there is about what are the barriers. Why do you think people didn't introduce themselves before?
I think there's a few points. I mean, is it because they feel they don't have the time to introduce themselves? You know, that's some of the responses that we originally got back. Is it because the names on the door, the names on the bottom of the letters that they send to patients? So these are some of the barriers that we initially came up with. For me, my response, and obviously, you know, Kate's response before she died was always one of, why wouldn't you do it? And it's the start of that therapeutic relationship, which, if anything, will save time in the long run, because by having that better, more trustworthy relationship, a patient is more likely to open up about their ailments and about their health concerns, which will save time in the long run.
So is it that people should give a name, like their first name, like Joe or Chris or whoever, or some health professionals like to use doctor, or surgeons like to use Mr. or something. Is there a difference, do you think, if somebody introduced themselves as doctor rather than my name's Joe, I'm Dr. such and such? Do you think it makes a difference?
I think it's whatever's comfortable to the individual and whatever's comfortable in the situation they're in, and it's very much bespoke to the person that they're talking to. Some people are very comfortable in using just their first name, but other people want to do it more formal, depending on the situation. And I suppose the next step to the campaign is, hello, my name is Chris, and I'm the surgeon that's going to be operating on you, or I'm, the doctor, whoever it may be, to put a bit of context behind that person that's introducing themselves. But it's whatever's comfortable to that individual.
Yeah, and we've seen recently, I've seen it on Twitter, the campaign to have it on scrub caps, so, such and such anaesthetist, such and such surgeon. Yeah. And I guess that's not really for the patient, because the patient is unconscious. But I guess that's part of it, is about not only who am I, but what is my role in your care is actually the next step to people feeling comfortable, isn't it? Because when you're lying, you get all these people coming in, and doing things to you or things, and people often, when you say to someone, oh, who was that? Well, actually, I'm quite sure who that was that came to see them or who spoke to them. So I think the barriers basically is, I think, accepting people as people. The next question is, we've got the campaign going, we've got it quite well accepted, as you've just said. How will we keep the concept going? How would you keep the momentum of the campaign going, do you think?
So there is a few things that we are doing, every single day to keep the campaign going. And it's like with any big piece of change within an organisation, we know change takes time. But once it's embedded in any organisation, be it in business, be it in healthcare, then it just becomes natural to actually do it. And because it is something that doesn't have to take a lot of financial investment, and it doesn't take that much time to adopt within organisation, there's various prompts and reminders that we can use. So, having name badges, or having posters on the wall, or posters on our office doors, reminding us that we should be introducing ourselves to each other and to our patients on every occasion that we can, is how we're going to keep the momentum going. And then also every year, my wife died on the 23rd of July. It was our 11th wedding anniversary in 2016. Every year we're going to use that day as an international hellomynameis day, so that we can keep relaunching the campaign almost, and keep spreading the word as far as we can and as wide as we can across the world, because it has been organically grown through social media and through word of mouth. And we have a lot of people that have spread the word across the world themselves without me or Kate being involved with that, and that's just the love and compassion shown toward the campaign and the simplicity of it.
Yeah, and I think it is that it's a very human story, isn't it? And it's a human response to something which. So one of the questions that we had was actually leads on to that, about how do we get it into the training of health professionals, and how's the campaign been reaching out to medicine schools, nursing, and other allied health professionals? How do we get young professionals or people who are just starting off on them have this embedded in them, I think is the question.
So I would love this to be used as part of education to the world. I've spoken in various universities, mainly in the UK at this stage, because they've invited me to go and speak at events that they've held. And I also spoke actually at the university in Tasmania around the campaign and around simple introduction. At this moment in time, all the invites that we get to speak come through to ourselves. We don't go out there and ask to go and speak at any events at this stage. And I suppose that's the thing. There is just me, who's travelling, telling the story. But it could be part of, medical education. We've got resources on the website that people can use as part of educational resource. We are likely to get into as many medical schools as possible, and I think in some way it is being used. Maybe not the exact campaign, but the introductions, the importance of communication, the importance of seeing the patient as a person and not just bed number 7 or whatever it may be. Using it as part of that training.
Yeah, and there's quite a some of the audience would know this as well. There's quite a discussion about the importance of communication, that being a doctor, being a health professional isn't just about the technical skills, but if you talk to your patients, can't talk to the people that you're trying to help, then you're not going to, get it. And it is seen as something that perhaps has got dropped off, that it's become very technical, very pushing through, and there are some health professionals are saying we can teach communication. It's not a natural gift. Anybody can be taught to introduce themselves, communicate. So
I think effective and timely communication is key in any scenario, not just in healthcare, but that effective communication and making sure that the patient is at the heart of those decisions and the communication is involved in them.
Yeah. And I guess with change, there's often resistance. Have you had resistance? I mean, have people actively said, well, we don't think this is necessary, or why would we bother?
Yeah, in the early days, and even we sometimes get that resistance, and without being derogatory to people that have been with an organisation longer, but it tends to be those people that have been in an organisation for 20, 30, 40 years that will come to us and say, well, my name's on the door, or my name's at the bottom of the letters, why do I need to introduce my patients? I haven't got the time to do that and things. But then over time, what we're finding is it's now more common not to introduce yourself. Sorry, it's more common to introduce yourself than the other way around. So those people that haven't adopted it in the early stages will have to start to come on board, because part of the organisational culture is to introduce yourself, and that will continue to grow. But we're trying to tackle it from both ends, universities, students, new starters on induction. We need to tackle those guys, but then also tackling it the more experienced end as well, who should be role modelling the way in an organisation, but we tend to find that all the time.
And those were, that covers the questions that people had pre-sent us. I guess it's interesting that culture takes a long time. It takes a lot of effort. There is only you to go to take it forward. So are you hoping are there other champions of the campaign that are working around this issue? Obviously people at AHHA are, but are there other champions? Are you getting champions in hospitals and things taking it on board and pushing it with their colleagues?
So we do have several individuals and organisations across the world that champion the campaign. I suppose my point of making it saying that there's only me is because of telling the personal story which is behind the campaign. It's quite difficult for other people to tell that story because it's very personal and emotional to both myself and to Kate before she died. But I know that we've got a huge amount of people that actively champion the cause. So, for example, inductions that take place in various NHS trusts in the UK, they use the campaign as part of the induction. They use the story as a way of having those inductions with new staff for them to make sure that they introduce themselves.
And somebody else had asked that question as well, so that's all right. So I guess we in Australia, people like to think we're laid back and friendly, and we would all say, how's it going? I'm such and such. But my personal experience of that in hospital is that's not the case, that people do sort of rush through. The other thing also, I don't know whether this has come up, but some patients like to be called by their name, and others, particularly older people, often like to be Mrs. Such and Such rather than, you know, Brenda or whatever it is. You know, I guess it's about the health professional gauging what the patient wants. So it's about a two-way communication, isn't it, really?
Yeah.
It's interesting that Kate, as a health professional, sort of thought, oh, this is not right. Why would we not do this ourselves? Some of the somebody has asked, has it been mandated? Is it compulsory for people to wear name badges in health services, in hospitals?
Not that I'm aware of. I mean, in terms of the campaign and in terms of what we would suggest to organisations is that everyone will have some kind of name badge or security card which will have their name on it. So why not incorporate the campaign logo into that kind of name badge or, you know, security badge or lanyard or whatever it may be. But it's not something that's, I don't believe, compulsory. And so in the UK, you know, everyone will have a form of ID on them, but not necessarily with the campaign.
And I guess the normal form of ID that somebody might wear would have a lot of their information around it, and the name won't be, the person's name won't actually be the most prominent thing that you see. And so I guess by having quite a simple hello, which is also part of it, isn't it? It's not just that my name is, it's hello is a greeting, and then having the name very prominently actually draws attention to the fact that they're a name, not just sort of the thing that has, this is the emergency code, and this is, you know, we've all seen hospital lanyards that have different colour codes on, and you could be lucky if you could work out what the person's name is from it. So I think, you know, we probably need to think about how big, I mean, I suppose if they don't use the hello my name, the actual logo, but actually have something prominent as their name, that would be good.
Yeah, it's a good starting point. And I suppose what a lot of organisations have done is when they've almost relaunched their own identity or they've reissued new name badges, then they've incorporated the logo then, because what we don't want this, you know, what we don't want this campaign to have is additional financial expense. But if they're having name badges anyway and they need to order new ones, then the name badges are the same price as ordering one without the campaign logo on. So we may as well use that, because it's a prompt for people to then say to whoever they're talking to, you know, hello, my name is. And just on the point there that you mentioned around what matters to the patient, you know, the next steps from this, which is something that started in various trusts, is, you know, hello, my name is Chris, and then what matters to the patient and what would they like to be called? Because, you know, my official title would be Christopher, but I prefer to be called Chris. Whereas, like I said, some people in hospitals might prefer to be Mr. Pointon or another name. So it's what's important to that person in the bed in front of the healthcare worker.
And I guess, you know, well, I like to be Joe, but my name is Josephine. I guess, but some people might like to be called Ms. Root or something like that. So, and certainly in my view, you know, a lot of older people really don't like people to be too familiar to start off with. So it's, and somebody here asks a question about ward rounds, which we've had a bit of exchange on ward rounds on Twitter and things recently, haven't we? And a few articles about it, and people saying that they find ward rounds quite not patient focused. They're about teaching, or they're about, you know, particularly when they're a teaching round, about the, you know, and this person Mike asked the question, you know, if the senior clinician of a ward round doesn't introduce himself, does that mean that other people will, or should they all introduce themselves? I mean, what would, you know, that could take quite a long time if there's 10 of them.
Yeah.
What would be your view on that one?
So I'm a firm believer, and probably from the background that I've had in the organisation that I work for, you know, for the last 17 years, is that the more individuals and the senior people in an organisation should be role modelling the way to, they should be role modelling the way to, you know, juniors and to other members of staff. but it would take a very confident individual when, you know, a senior person has not introduced themselves to then say, "Oh, hello, my name is Chris." But we've all got our own voices, and if we're confident enough to do that, then I believe we should do that. And in time, that will hopefully change the mindset and the way in which the more senior members of staff and the senior clinicians will introduce themselves as well. But they should be rolled away with junior members.
So this is a campaign that started from sort of a grassroots, very much a grassroots campaign, an idea that has gained momentum. How easy or difficult is it, do you think, for patients or their family, their carers, their friends to influence change in this way, to influence change in a health service?
I mean, I was fortunate enough that Kate was obviously within, you know, within the profession, so it was quite easy for her to question any decisions that were made because she had the knowledge and experience to talk about that. From my perspective as a non-medic, I suppose it depends on how confident you are to question what's going on. I mean, I'd have no qualms in questioning something that was told to me if I didn't understand it, but some people, when they're in a vulnerable position, you know, lying in a hospital bed, they might not question that. So if they're confident enough to question it, then yeah. And also if we're not being introduced, sorry, if people aren't introducing themselves to us, then we should say, "Oh, excuse me, and what's your name again?" Because, you know, we have the right to ask that question. And it's keeping it simple and keeping it consistent is the best way we can make a difference using experience.
Yeah, and I think people, you know, when we're allowed to question, health professionals, I think many patients, many individuals find it very difficult to question a doctor.
Yes.
You know, doctor knows best is my favourite saying.
No, it's that power. Well, there's that power sort of imbalance that we feel is there because we're vulnerable, we're sick, we're lying in a hospital bed, and you've got doctors or consultants or whoever coming, probably standing over, which is another thing that we can do to make a difference by getting down to the same eye level and talking, you know, on the same eye level to try and counteract some of that power imbalance. But, you know, as a patient or even as a relative, so like obviously I was, you know, Kate's husband, you know, I should be able to ask any questions that I of the doctor or healthcare being provided.
It's a good point about getting down to the level. I hadn't really thought about that, but it's actually, you know, mostly when you're lying in a hospital bed, the doctor will come and either stand at the end of the bed or might come and stand next to you if you're lucky.
Yeah.
They very rarely, in my experience, sit down next to you. I don't know whether that was your and Kate's experience. And
that's something that, you know, another thing that Kate was passionate about was, you know, getting down to the same eye level as the individual that you're talking to. So I know in some hospitals they've now adopted the stance of that they have the fold-up stools that they carry around with them when they do the ward rounds, so that they can just sit down next to the bed, same eye level. And that's something that's a fairly inexpensive way of solving that problem, rather than standing over somebody at the end of the bed.
Oh, so they're carrying a little portable stool. That's a good idea. I wouldn't have ever thought of that.
The collapsible ones.
Somebody here's asked a question since you've been doing the campaign and you've been talking to a lot of health services and hospitals, whether you notice a difference between the way people behave in, say, paediatric and children's hospitals than they do with adults. Do you think children's hospitals, they do it better? I
think they do in the main, but I think a lot of the time they'll introduce themselves to the parents of the child as opposed to sometimes the child, when actually it should be to everyone. And I get that, you know, the child, you know, whatever age they are, they still need to have that interaction with the person that is going to be looking after them. But then the parents are probably more frightened than the child is because of, you know, naivety and things like that. So, but I do see that. I mean, I was in a children's hospital in just yesterday actually, down in Melbourne, and you could see it going on, you know, all the time. And they make it a bit more fun, depending on the age of the child as well, you know, because of the nature of paediatrics. But
so they could still improve. I think is what we're saying. I guess this is actually quite, I think, a question. That do you think there's something intrinsically different between having a name badge and actually introducing yourself? And I guess I would add to that, do you think people think that having the name badge is enough, so that they shouldn't actually physically have to introduce themselves? They could hide behind the badge.
They could, but I don't think they should. I think, you know, you can take away all the name badges and everything. If people are introducing themselves, that's the main thing. That verbal communication, or even not necessarily the verbal communication. It could be in a sign language. It could be other means of doing it. And I think, will we still be on?
Yeah.
Oh, and I think the name badge is there as a reminder to the patient or to the family members who they're actually talking to. You know, because sometimes you could introduce yourself, but within 2 minutes you'll have forgotten who it is. Whereas for people that are introducing themselves, they then got that little prompt reminder, just a little glance at the name badge, say, oh yeah, that's Joe, or that's Chris, or whoever it may be, just for the patient to remember who it was. But yeah, the most important thing is that verbal or any other form of communication, and it's something that we can do on the telephone, we can do it via email, we can do it, you know, face to face. It's not just the face to face interaction that counts; it's every communication that we have.
And that was actually going to be my next question, because we talk a lot in Australia about telehealth and virtual consultations, and with distance, you know, telehealth, you don't have the distance problem so much in the UK, although there still are areas that it can take a long time to get to medical care. But, you know, do you think it's, I was thinking whether there was a difference if people automatically might be better at introducing themselves because they're using something like telehealth, but they still are using a telephone consultation, but the experience seems to be that it's, I mean, I guess as well as being nice and being a human thing to do you think it actually makes a difference to the quality of care and to perhaps making either the actual quality of care or making or doing more than just making patients feel good?
Yeah, I mean, in the UK we've had studies done which show that patient experience, not necessarily patient outcome, because the outcome of health is determined by other factors, but the patient experience of being in hospital has improved with the simple starting point of an introduction, which then leads on to better communication. And we have got sort of similarities between those hospitals and those trusts that have widely adopted the campaign, that have got better, you know, quality assurance scores on the back of patient experience. And like I said at the very start, you know, it's one of the things is why would people not want to introduce themselves?
Yeah, and I guess a couple of people are asking that. I mean, this next question, you know, clinicians often respond well to research supporting a change, so they want the evidence. So I suppose you've just touched on that some of the patient recorded data is showing that there is higher satisfaction, and that's evidence. And I mean, it would be hard to show health outcomes. The campaign hasn't been going long enough apart from anything else. It takes a long time, and there's a lot of other factors at play in things. In England's a very multicultural society.
Yeah.
People wouldn't know this. So is Australia. Do you think there are cultural differences? Do you think there are different? Do you think the perhaps the lack of a common language can be as big a barrier as name? Has this been touched on in the campaign? Anglo, hello, my name is. So
I mean, it has been, like I said earlier on, it's been translated to different languages within the UK. So, you know, in certain parts of Wales, it's very much a Welsh-speaking, you know, community. So we've translated that into Welsh. I know it's been translated in other countries across Europe, and also within the UK. You know, we have multilingual healthcare workers who will use that as part of the introduction, and they'll have it bespoke to the individual that they're talking to, which is how it should be. It should be bespoke to that person across campaign. But just touching back on the research side, we've had some research done. I mean, it's not been formal research. It's not something where you can clearly say that this is having a huge difference on this. But we've also got so many examples and evidence of where it hasn't happened, which has had a negative impact on that patient experience. And from the way in which my mind works, it's quite simple. We shouldn't need to do loads of research on this to say that it's working, because it's a simple concept that works.
Yeah, and I think sometimes the simple things are always going to be the easiest to implement, but the most difficult to measure. Mm-hmm. And it would strike me as that it's pretty straightforward that you should introduce yourself. It would be part of being a human being and talking mm-hmm. to another human being. I wouldn't have thought we needed a campaign, really. Would your hope be that that eventually you don't need the campaign?
Yes, eventually. I mean, my wishes for the campaign is that it's across every country in the world, or it's making a difference in every country in the world. And yes, it's got a nice logo, it's got the smiley face, which is another part of the campaign. It's not just about saying those 4 words. But if it can be adopted, like I say, across the world, then yeah. And if that happens in the next, before I die, then that'd be great, but I doubt it will, to be honest. But yeah, I think there'll always be a need for this campaign or campaigns of similar natures around compassionate care and communication.
Yeah, and it's not just, I guess some people say it's not just for hospitals, is it? It's for people going into people's homes, for care in the community, for GPs, mm-hmm. For aged care. When somebody's in residential aged care, you would expect that the people who are caring for them, who are not necessarily health professionals, mm-hmm. but personal care assistants, other people, everybody we all are the patient experience in a sense, and so we need to be aware that the cleaners, everybody have an impact on people. So everyone introducing themselves across sectors, not just in acute care, is part of the thing. If you were saying to the people who are watching and participating, what would you want them to do to spread the word or to take the campaign on? What are the things you'd like to say to people that they could be doing?
I think, like I said earlier on, the biggest part of the campaign and the big selling points of the campaign are that it is so simple and easy to do. It doesn't take much time, and the more people that start either using it as part of their own practice or as a consumer, if they're not happy with people not in themselves and they're comfortable to question why they've not, then to ask those questions and just to share, share the YouTube video, share the website with as many people as possible, because that's how the campaign becomes so successful. It's become as big as it has been because of the organic growth that we've seen from people talking about it, using their own experiences, both in a positive and the negative way, because a lot of people will focus on the downsides of when they've not been introduced to it. But then there's also a whole host of people that use examples where they've had a better experience because they were introduced.
And I think, I think that's probably the best, what we're all hoping for is that people have a better experience, because if you feel more comfortable, you're much more likely to share. Mm-hmm. As a patient, you're more likely to actually say what the problem is. If we all want to move towards sort of patient-centered care, then it's what the person wants, and then you're more likely to say what you want to someone where you've developed a relationship with them. I think we've pretty much exhausted all the questions. Is there any? No, somebody's had a thought. So Tracy says, could it be approached with a two-way interaction rather than an us and them? So who's responsible for the introduction? Should a patient introduce themselves should the patient take the initiative? I think you kind of touched on that, but do you want to say anything about that?
So this campaign, albeit born in healthcare, is something that's applicable in every walk of life. It's two human beings interacting with each other. So, irrespective of who starts that conversation, who starts and who prompts that introduction, then, we're all human beings. We've all set or a communication method that we can use to introduce ourselves and start that relationship. And I don't feel that it should be that for somebody else to start that conversation. And this is how the conversation started. Sorry, how the campaign started, because Kate and I were talking about the lack of introductions, and rather than just letting that go and not doing anything about it, we decided to do something about it. And I think everyone in the world can make a difference in some way, shape or form, and everybody can make that difference. So why not introduce ourselves to each other and to the doctor or to the nurse or whoever it may be, rather than waiting them to do it and saying, well, they didn't introduce themselves. We can be the start of that change.
And I think that's, I guess, consumers, we have a campaign called Choosing Wisely in Australia. I don't know whether there's a UK version. It came out of the US, I think, didn't it? Choosing Wisely, or Canada, one of the two. And it's one of the key things about the Choosing Wisely campaign is here are 5 questions you should ask a doctor whenever you see them, or your health professional. And one of them has been said to us as we're working with the Choosing Wisely Australia, is that people are wary of asking questions because they think that the person doesn't want to answer them. And it's been suggested that what we need is doctors have a little thing on their desk, particularly GPs, but also specialists, when you're seeing them in their rooms, is that I'm happy to answer questions, or you can ask a question, or the practice could say. So you could have a GP practice that says, we're part of the Hello, My Name is Payne, and you can expect our staff to introduce themselves. So is that kind of some of what the campaign's to do, to get them to see that it is part of the culture?
Yeah, like I said, it is just the starting point of an open and honest relationship, a therapeutic relationship, where I firmly believe, and it's said by other people, that by having that introduction, people are more open and honest with conversations, and they probably will ask those questions that they might not have asked in the past. And you should be able to ask your healthcare provider or professional, I believe, any question that you've got, because it's your health at the end of the day, and you shouldn't be restricted to what questions you can ask. And I know that's maybe difficult, but I don't feel why you should be restricted.
And I think that answers the question that we've just got up on the screen now about, there's a strong internal process and a medical hierarchy about who can ask questions and who's in charge. There's a power imbalance between the patient and their care, and particularly their family members. Family members often feel that they want to ask the question, but you probably felt like this yourself, that you want to ask a question, but should you ask it? Are you going to look stupid? I think the idea of that there's no wrong question. There isn't a wrong question. There's not a stupid question when you're a health consumer. How do we persuade, how can we as a consumer organisation persuade people that there is no stupid question and no wrong question, do you think?
I think it's briefing it in exactly that way. At the end of the day, they're concerned about either their own health or their loved one's health, and don't feel like it's going to be a question that they're going to get laughed at, because I'm not in healthcare, like I say, so a lot of the questions I had, I could ask Kate because she was in healthcare, so she knew the answers anyway, so I was quite fortunate from that perspective. But if Kate wasn't in healthcare, then I'd probably ask those stupid questions, because it might be a stupid question to me, but they might think it's a stupid question, but to me it's important, and I don't know the answer to it, and I want to know, why have we reduced the drug intake, or why have we moved wards, or things that they might not have told us that they should probably have told us, it's not a stupid question.
And I guess you had Kate,
Mhm.
and who could explain those things to you in a way that she knew you would understand as a non-medical person.
Simple terms.
But I need them very simple too. I think most of us do, particularly when you're under stress, and it's a very emotional time, isn't it? And it's a very difficult time. How about somebody who didn't have someone else to interpret for them? Did you find that health professionals were prepared to put it into terms that you could understand, or?
Some of the time, yes, but some of the time they would answer it in a very medical response, which, I would find myself remembering what they told me, writing that down, and then when they'd gone, Googling what it meant, which isn't probably the right way of doing it, but
good old Dr. Google.
And the other part of it is, what you got to remember is, like, Kate was in a bed, she was having a sleep, I was asking the questions. I've then got to then try and reiterate a lot of that message back to the wider family and friends, who I've got to try and then put it in a way that's understandable to them. Hence why I tried to keep it as simple as I could, because most of our family members are not in healthcare either. So for them, they wanted the simple terms, same as myself. Whereas Kate, when she was talking to her doctor friends, they would speak more medically than what she would speak to me about it.
And that's fine, isn't it? If Kate was talking to friends who were medical, or even the medical staff, and they were having a conversation, then that was okay to speak that. But and I guess there were times when you were there and Kate was so sick.
Mm-hmm.
I mean, that you had to be the one who had to ask the questions about what was going on and things like that. And I think, the experience is that we do all tend to go into our own jargon.
Yes.
And we all do it.
Yeah.
And just expect that, and just by giving information isn't checking that somebody's understood it.
Mm-hmm.
Did you find that people were prepared to sort of check that you'd understood?
To be fair to them, they did sort of say at the end of when they'd explained something, is there any other questions, or are you happy with that? Sometimes you would say yes, even though actually you're thinking, I might not actually have understood that, and then you would go away and just do a little bit more research into it, because you can sense that they're wanting to go see other patients, and you don't want to take up time from them seeing other patients. But it was on occasion, good that they said that, but then other occasions they gave a response and almost like we're out of the room.
Because
some of the jargon that they use is medical.
And it has, to a sense, it can be hard to convey the information. And I suppose, did they ever offer to give you written stuff that reinforced what they were telling you? Did they offer you materials?
We had some material, but the material was more around, as a partner or as a loved one to somebody who's got cancer. It was more the generic publications that are available about financial help, or around emotional help, or what changes you might see in the person that you in your loved one. So there was that offered.
But it wasn't personalised.
No,
it wasn't Chris and Kate.
No.
Even with just your name on, these are some of the things that you might have.
Mm.
I think the strength of the campaign is that it does make it human. It does make it personal. It makes it, it reminds us all. We often talk about consumer-centred care, and we can have a big debate, as people often do, about whether we should use the word consumer or patient or anything. We sort of thought, we think that it actually should be about people. I think it would be better if we talked about people-centred care, rather than consumer or patient. Myself, I think that would be better. You're writing a book about supporting patients. Do you want to talk about that a little bit? When's it going to be out?
Yeah. And just on the point you made there around person-centred care, obviously my background is retail, and one of our beliefs within our organisation is that every decision that's made should have the customer in mind. And from a healthcare perspective, every decision that's made within healthcare should be with the person or the patient in mind. And that's what I sort of try and say in a lot of the talks that I give. It's keeping that, you know, patient in mind with everything. But yeah, in terms of the books, you know, my wife wrote 2 books. One called The Other Side, which was seeing it as a doctor through the eyes of a patient, and the second book was called The Bright Side, both of which are still available to buy with all the profits going to charity. And I'm writing a book which it's very much a story of Kate and I's life together, but also seeing it through from my perspective, and hopefully providing hints and tips to people that might be going through something similar to what I've been through on how to cope and different coping mechanisms that I adopted over the years of Kate being terminally ill. You know, things that I've done since Kate passed away. Obviously, the campaign features quite heavily in the book as well. It also features a lot of Kate's blogs with my interpretation of those blogs. And like I said, the whole point of me writing the book, there's three reasons. One is to almost get everything out of my head onto paper to help me with the grieving process. The second part is to raise a huge amount of money for one of the charities that we support, because all profits will go to that charity. And the third part, like I said, is to help other people, or if it helps one other person going through something similar, then it's been worth writing. I'm hoping that it's going to come out at some point this year. I was aiming originally for the 23rd of July, but that's a big ask, I think. But so I'll say this year it will be out.
Sometime this year. And I think, you know, I think people do learn from other people's experience, you know, and I think that's really good. I think we might wind it up now. I'd just like to say a really big thank you to you, Chris, for sharing your story and being willing to share what must be a very difficult experience to share. It must, every time you talk about it, must bring some of it back. And I'd like to thank you for doing that and sharing your experience with everybody. And we'll certainly look to how we can help promote the campaign through CHF and work with other organisations to make sure that people have a better experience. So thank you so much.
No, thank you very much indeed. Thank you all.
Okay, thanks.